What if we've been looking at erectile dysfunction the wrong way? Recently, I was given an online lecture on shockwave therapy for erectile dysfunction. And while I was talking about vasculogenic erectile dysfunction, it suddenly hit me. What the heck do I actually know about vasculogenic ED? You know those moments when you suddenly realize you've only been seeing half the picture. And that's a dangerous place to be as a physician. That single question eventually turned into a scientific paper published online in the International Journal of Impotence Research on June 26th. You'll find a link in the description if you'd like to read it. Our central idea is simple. Erectile dysfunction may often begin when the penis is not erect. We call this concept chronic hypoperfusive erectile dysfunction, or CHPED. My name is Dr. Stefan Buntrock. I'm a board-certified urologist and specialist in sexual medicine. Right after the lecture, I began my research. Vasculogenic ED was defined in 1982. Initially, it meant that narrowed arteries would prevent the penis from filling with blood in an adequate amount of time. But over the years, we have started to call any non-psychological cause vasculogenic. I don't think that's necessarily wrong, but I think it's become imprecise. Because when I treat patients with shock waves, my goal isn't simply to improve arterial inflow. It's to restore tissue health and, ultimately, tissue perfusion. That's not the same. Whenever I talk about low-intensity shockwave therapy, everyone says, yeah, it improves blood flow. I've kind of gotten allergic to this because through the years of experience with this method, I've discovered that it doesn't work that way, and I still have non-responders. Somehow they were trying to tell us something. Why are there men who don't respond? Maybe their problem isn't in the penis at all. Maybe it's upstream in the pelvic arteries, in the small pelvis where pelvic arteries could restrict free blood flow into the penis. I knew exactly one person who might have the missing piece, Professor Nicolas Diem in Switzerland, because that's what he does every day, placing stents in pelvic arteries to restore penile blood flow. So I called him up to discuss the matter. Turns out he had just published a paper on over 1,000 endovascular procedures for that purpose. What he found was the other side of the coin. Only about half of his patients yielded meaningful clinical improvement. That puzzled me. So I'm sitting here with one half of the picture, and he just provided me with the other half. We decided to work together. Vasculogenic ED clearly needed an overhaul, because if it's vasculogenic in the traditional sense, then you would expect something like 90% improvement rates, right? Why not 100? Nothing in medicine works 100% of the time. If somebody tells you otherwise, be skeptical. When I started working on the available literature, something happened. Suddenly, I realized that I was on an almost archaeological journey because everything I had discovered was already there. It was established knowledge. The pieces were already on the table. Nobody had put them together before. What I found was this: aging, disease, and lifestyle alter tissue perfusion in the penis in the resting state. That is enormously important because in the resting state, perfusion is very limited, only a few milliliters per minute. Think about that for a second. A few milliliters of blood, that's all. Perfusion means oxygenation. Just a tiny fraction less perfusion can have major impact on tissue integrity. Tissue oxygenation can drop substantially. The penis is contracted in its resting state. This point cannot be overstated. This is why autonomic dysregulation may turn out as the big destroyer one day. Imagine living in permanent flight or fight mode for years. Add hypertension, diabetes, high cholesterol, and you have the recipe for the perfect storm. That's premature penile aging, resulting in fibrosis of the cavernous bodies, what I call the marshmallow penis, venous leakage, small vessel damage, loss of nitric oxide, and so on. There is scientific reason to divide the damage into 3 stages. Tissue regeneration may only be possible until an intermediate state. In severe tissue alteration, prosthesis placement appears to be the only option left. The interesting part is this. Sometimes stenting is exactly the right treatment. Sometimes it probably isn't. And if we don't distinguish between arterial disease and tissue disease, we'll keep mixing 2 fundamentally different conditions. That's why we proposed CHPED. And I believe this is only the beginning of a much bigger field. Penis longevity. I'm Dr. Stefan Buntrock, always copied, never matched.